Good afternoon, everyone. I'm Tariq Al-Touki. I'm the clinical lead for the assisted conception unit at Guy's Hospital and the HFE person responsible. It's an absolute pleasure to be with you today to discuss the updates in fertility guidelines. Originally, the NICE Fertility Guidelines were published in 2004, then they were updated in 2013, and then they were updated again in 2017. Of course, we don't have time to go through every part of the guideline, but we will go through the important aspects and really what is new and how we've integrated that in our practice. So the scope for this webinar is to review the evidence-based practice in the evaluation of the infertile couple from a primary care perspective, and we will also delve into secondary and tertiary care to some extent. We'll examine the indications for early referral of the infertile couple, and I think this is really important point, and I will go through why that is increasingly important nowadays. We will understand the predictors of successful infertility treatment, which I'm sure many of you will already know what the main pillars predicting the outcome of fertility treatment are. And we will also cover the counseling service that we are very proud of in our assisted conception unit at Guy's Hospital. So without further ado, we will cover the updated version of the NICE guidelines published in 2017, which covered the main causes and treatment options of infertility, whether medical, surgical, or assisted conception. Now, our talk today will be mostly covering assisted conception, and I will try and not take too much of your time, maybe 30 minutes, and then we will have enough time at the end for Q&A, and I would love to hear your questions, and we can go through any queries you might have. Now, the NICE guidelines acknowledged how common infertility is, 1 in 6, 1 in 7 couples, and there's an increase in prevalence of infertility since the original publication of the NICE guidelines in 2004. The decrease in the number of couples seeking help, and I will also present some data from the HFE register today about how access to infertility is increasing and the demand for services is rising. Of course, we have to focus on patient-centered care, and also treatment by specialist team increases effectiveness and improves patient satisfaction and reduce patients' complaints. So I think these are all pillars of what we're trying to achieve here at Guy's and St. Thomas's. Now, I mentioned earlier that the demand for infertility treatment, and particularly assisted conception, is rising. And you can see on the graph on the left side, the chart showing that the majority of treatment cycles carried out in the UK are actually funded privately by the couple themselves. NHS funding, and we'll talk about that in a moment, is not the predominant source of funding for infertility treatment. And if we look at the two graphs on the right, you can see that the number of cycles is going up every year on year. And in this year, 2020, 2021, we predict that the total number of cycles will actually exceed 80,000 cycles of IVF in the UK. And equally important, we look at the graph underneath the top one, and it shows that the success rate of IVF treatment is also increasing. Now, I want to spend just a couple of minutes on those two charts and expand on them just a little bit more. And you can see here that if you look at different age groups and look at when we started the HFE register in 1992 and recorded the success rate per treatment cycle, you can see that the treatment cycle success rate has increased over the years, over 30 years, almost 30 years, by 3 times. We started with 5 to 10% live birth rate per cycle, and we're now, for the younger age groups, the success rate is well over 30%. Now, what is also important is to look at the success rate of the older age group, 43 and above. And unfortunately, you can see here in the graph that despite the huge improvement in the technology, in our ability to overcome subfertility, we're still struggling with this age group. of 43 and above, the success rate has not really improved that much over 30 years, which is quite a long time. Similar data has actually been published 4 years ago by the American Register, this heart data, and it again shows that there is a massive improvement in the success rate in the younger age group, even up to 40, 41, 42, but more predominantly in the younger age groups, with very little improvement in the older age group. And this is because of the biology of egg reserve and egg quality, which will override any improvement in technology and will stop the success rate from being increased exponentially with the improvement in the technology we use. Now, I also want to touch on the availability of NHS funding for IVF treatment, because we said that the demand is rising, but unfortunately, we have seen in the last decade or so that the funding has not improved. In fact, in the last few years, it has actually started to go down, particularly for the younger age groups, where you would hope that the NHS funding will be available because they have the better success rate. So I think we need to bear that in mind, particularly when we talk about criteria for early referral. Funding is not increasing and possibly reducing, particularly in and around London. If you look at a chart of how much funding is available for IVF cycles across the UK, unfortunately, London is the worst, and the availability of funding is under 30%. So that means that we really need to be very vigilant about how we can refer patients as early as we can, because A, they have a better success rate when they're younger, and their access to the NHS funding may not be actually for more than one cycle. Therefore, we want to give them the best chance of success with the very first cycle. So the definition of infertility, as indicated by the NICE guidelines, particularly in the last update, with unprotected sexual intercourse in women of reproductive age of 1 year. So after 1 year, we really need to think about, do we need to refer this couple as soon as possible, or the age and the ovarian reserve allow us to maybe perhaps try one or two things, a few investigations, a little bit of expectant management before we refer the couple for assisted conception. So if the female age is 30 years or over, that's an indication for early referral. If we have a known cause or history of any predisposing factors, so patient who's known to have history of ectopic pregnancy, history of endometriosis, history of abdominal or pelvic surgery, particularly reproductive surgery like myomectomies or ovarian cystectomies, which can actually influence the ability to conceive through a tubal or a peritoneal factor, then we need to think about early referral. If they have had treatment that may result in infertility, particularly chemotherapy, particularly oncology treatment, particularly treatment directed against, for example, ovarian or pelvic peritoneal endometriosis, then we need to think about early referral. And that's from a primary care perspective. And maybe this is an area where perhaps we need to discuss a little bit more at the Q&A section of the webinar. Again, one of the reasons why we talk about early referral, particularly in relation to age, is that a lot of the patients now present later in their reproductive years. And you can see here, this is, again, chart from the HFE register showing that the conception rates have increased in the older age groups, 35 and above, 40 and above, and actually reduced in women under the age of 30. So again, patients tend to present later, and therefore an early referral may be more indicated for those patients with an age of 36 or higher. The reason for that is the conception and the fertility rate will decrease markedly after 35. It declines with age anyway, we know that, but it will reduce markedly after the age of 35. So from 36 onwards, you would expect that there is a rapid decline in fertility per 100 women. So the live birth rate, again, as we mentioned earlier, is significantly reduced after the age of 38. So you can see that there is a faster decline in the live birth rate per embryo transfer in women aged 38, 40 and above. So again, we have to be very careful. And this is one of the issues that a lot of patients discuss with us when we see them in clinic, is that they would have preferred to have been referred a little bit earlier, particularly when you have surprises like high FSH or low AMH indicating low egg reserve. Now, the initial assessment, which is predominantly carried out in primary care, should involve a semen analysis, which is assessed according to the updated 2010 WHO parameters. And that will include the volume, the count of 15 million or higher, overall motility of 40% with 32% progressive motility, and morphology, normal morphology of 4% or higher. A lot of couples that we see being referred, there will be a focus on the female partner, and we don't have the semen analysis attached to the referral in many cases. And again, this is something that can delay patients accessing treatment, because we would have to request the semen analysis, book another appointment, and that can cause further delay in starting treatment. What is also becoming extremely important is that we have to assess the ovarian reserve, because this would be one of the factors that would indicate early referral, and actually it would also indicate speeding up the treatment, because with a low ovarian reserve, time is of the essence. And the definition of low reserve by the NICE guidelines, and actually by other professional societies, including BFS, including the European Society of Human Reproduction, is around ultrasound where we see 4 or less antral follicle counts, AMH level of 5.4 or less, or a baseline day 2 to 4 FSH of 9 or higher. So any FSH above 8.9 is considered to be a marker of egg reserve. But very importantly, we need to remember that FSH should only be measured and assessed for evidence of ovarian reserve markers when it's done in the first 4 days of the menstrual cycle. FSH done in the luteal phase, which is something that we see quite often, that when the patient comes for luteal phase or day 21 progesterone measurement, we will also get the FSH and the LH and the estradiol done. Well, unfortunately, the FSH will not be informative at that stage, predominantly because it will be suppressed by the progesterone level. And therefore, if you find an FSH of 6 or 7, that doesn't mean that the patient has normal ovarian reserve, because that is a suppressed FSH level and doesn't reflect true ovarian reserve. So I think this is just an important point that we need to remember when we assessing ovarian reserve. We don't use ovarian volume, we don't use inhibin, and we don't use ovarian blood flow as measures of ovarian reserve assessment. Of course, a lot of our primary care colleagues will want to arrange an ultrasound scan, a pelvic ultrasound scan that will include an assessment of the ovarian reserve, such as the antral follicle count. It would be useful. Quite often, again, on the reports, we see ovarian volume. We said we're not really going to use ovarian volume as a marker of ovarian reserve. We just need number of follicles of size less than 10 millimeter, 2 to 9, and that usually gives a relatively good idea of what the ovarian reserve is like. And the threshold that we want to see is 10 or more. If we see less than 10 on both ovaries, that could be a sign of low ovarian reserve, and that would prompt an AMH and an FSH baseline measurement. Most of the time, we do the assessment of tubal patency in secondary care, and we often use hycosi or hysterosalpingogram. And when there is suspicion of peritoneal pathology or endometriosis or adhesions or history of infection or ectopic, then we may recommend a laparoscopy and dye test, which is the gold standard in assessing tubal patency. Now, this is as far as assessment is concerned. And once we have completed the assessment, we need to start thinking about treatment strategies. The simplest strategy is ovulation induction. And NICE guidelines had 1 or 2 things to say about ovulation induction. And they said that at least 1 cycle should be monitored by follicle tracking. Number 1, to ensure that there's been an adequate response to the ovulation induction regimen. and number two, to make sure that there is no over response or overstimulation, which could, of course, as you know, increase the risk of multiple pregnancy. They also mentioned that Clomid should not be used for more than 6 months, and I think that's common knowledge now, and a lot of our primary care colleagues will not prescribe Clomid for more than 6 months. And I'm not sure whether this applies to letrozole or not, and in the last 2-3 years we have been using predominantly letrozole because it has a better effectiveness and a more favorable side effects profile. Again, ovulation induction in our clinic is carried out with follicle tracking in most cycles, but at least 1 or 2 cycles at the start of the treatment. Now, if we look at the main category for as a cause of infertility that we find nowadays, it's interesting that unexplained infertility is probably the most common cause of infertility or conception delay. It represents 25% of cases we see, and it's actually an indication for assisted conception treatment in the UK for just over 40% of IVF cycles carried out. So if you look at the HFE data over the years, it will tell you that unexplained infertility is the indication for treatment with assisted conception technologies in 40% of the time. With unexplained infertility of over 2 years, we generally tend to offer IVF treatment, particularly if the age, as we mentioned, is 36 or above, and we tend not to offer ovulation induction. We tend not to offer superovulation and IUI, particularly if they've been trying for more than 2 years. If the patient has been trying for less than 2 years, then we may offer IUI, and we've got a Cochrane a systematic review which has recently been accepted, just to highlight that in patients who are over 36 years of age, trying for 2 years and above, the optimum treatment is IVF rather than IUI. IUI, again here, don't offer for unexplained infertility, mild endometriosis or male factor, particularly if unexplained infertility for more than 2 years. We tend to offer IUI when there is difficulty with intercourse, there is a ovulatory disorder, and we combine IUI with ovulation induction. We offer IUI, of course, for same-sex couples, or in cases of male partner being HIV positive after sperm washing. When it comes to IVF treatment, the definition of a full IVF cycle is an episode of ovarian stimulation resulting in egg retrieval with the transfer of all suitable fresh and frozen embryos. Now, unfortunately, the current eligibility criteria will not offer this full definition of an IVF cycle to most of our patients, and there is a limit on the number of frozen cycles. So if a couple, for example, had a fresh cycle with a fresh embryo transfer, and then they ended up with 4 or 5 frozen embryos, majority of the time they'll only be allowed 1 or 2 frozen cycles, which can put pressure on the couple to transfer more than 1 embryo, because after the 1 or 2 funded frozen cycles, they will have to pay for subsequent frozen cycles. So again, that's something that we are campaigning to change, to make sure that we are using the NICE guidelines definition of a full cycle, which includes the transfer of all frozen embryos subsequent to the fresh cycle. Now, the eligibility, again, has been addressed by the NICE guidelines. And again, it's important that patients are aware before they start treatment how many cycles are offered. The NICE guidelines recommended 3 cycles under the age of 40 and 1 full cycle age 40 to 42, provided the patient has not had any previous IVF treatment. And also we discussed with the couple, of course, risks of pregnancy at the age above 40. And of course, this is a very hot topic. The media will always jump on the eligibility criteria, and therefore it is crucial for primary, secondary, and tertiary care to make it absolutely clear to the patient before they start treatment how many cycles the NHS is willing to fund for them. We don't offer natural cycle IVF. The evidence doesn't support the effectiveness of this approach. It's better to use standard ovarian stimulation. We don't use FSH dose of more than 450 daily. And again, this is supported by evidence from systematic reviews. And we offer scanning and estradiol monitoring for safety measures throughout the stimulation if we thought that the patient was at risk of ovarian hyperstimulation syndrome. We don't offer adjunct therapies, particularly in relation to growth hormone, DHA, and I know that a lot of our primary care colleagues will be discussing or being asked by their patients whether they can take DHA supplement or CQ10, coenzyme Q10. We tend to provide patient with evidence that those supplements do not actually enhance the chance of success. And the evidence for that is quite clear, that they don't increase the overall chance of success, whether with treatment or naturally. We use HCG as a trigger because that can enhance the chance of success. But in patients at high risk of ovarian hyperstimulation syndrome, we use a GnRH analog trigger, freeze their embryos and transfer their frozen embryos in subsequent frozen embryo transfer cycles. And with that, we have been able to minimize the risk of hyperstimulation syndrome to far less than 1%. And luckily, we don't see this condition anymore. With regard to how many embryos we're allowed to transfer, the guidelines suggest that in the first cycle with patients under the age of 37, single embryo transfer is recommended, particularly if they have a top quality embryo. After the third cycle, from third cycle onwards, after the second, they may be offered double embryo transfer. And I will talk about the risk of multiple pregnancy and how much we have achieved in the last 10 years or so since we have pioneered the concept of one embryo transfer at a time here at Guy's and St. Thomas's Hospital with the help of our mentor, Professor Peter Brody. Again, aged 37 to 39, patients are recommended to have single embryo transfer if they have a top quality embryo, but if not, they can have 2 embryos transferred. Age 40 and above, they are allowed up to 3 embryos. But there is a recommendation that 3 embryos can only be transferred under very strict circumstances. But really, most of our patients in that age group will have 1 or 2. Now, why it's important to talk about the number of embryos transferred? Because the risk of multiple pregnancy is significant. There are risks to the mother. There are risks to the babies, particularly if it is higher order multiple pregnancy, which luckily we don't see anymore. But of course, the cost of a multiple pregnancy to the family, to the NHS, to the society can be quite significant. What I want to reassure you about, which is really important, that we have taken as a profession, we have taken really a very strong stance on trying to minimize the risk of multiple pregnancy with IVF treatment. And as you can see here, since the introduction of one at a time policy in 2007, there's been a gradual but significant reduction in the live birth rate with multiple pregnancy in the UK. And the latest figures in the HFEA publications is 6%. And I would also like to inform you that our own multiple pregnancy rate in 2020 in ACU at Guy's is only 3. And this is just marginally above the natural multiple pregnancy rate, which sits at 1.22. So I think we have done a huge amount of work to minimize the multiple pregnancy rate whilst maintaining a really good success rate. So we have achieved the balance between effectiveness and safety for our patients. And I think this is something really important for our primary care colleagues to know. Now, as we are in London and we know about patients who may come and require assisted conception treatment, and they have conception delay and they are viral positive, that we are able to care for them. And the NICE guidelines suggest that the risk of transmission is negligible from a positive man to his female partner if they are compliant with therapy, if they have very low viral load, no other infections are present, and they only practice unprotected intercourse at the time of ovulation. Now, what is also important, and I think we share this responsibility with our primary care colleagues about the patient's lifestyle, because patients will listen to their general practitioners when they talk to them about lifestyle. It's important for them to know this and hear this message before they attend the fertility clinic. It's really important to optimize the BMI before starting treatment, particularly the raised BMI group, 30 or above, because that can increase the risk of miscarriage and diminish the overall chance of success. Of course, smoking for both men and women is really required to be quitted before we start. They won't be eligible for funding from the NHS if they have been smoking within 6 months of treatment. And alcohol consumption, we would recommend that they reduce alcohol consumption to less than 5 units per week. Now, let's talk a little bit about male BMI, which is something that is becoming more important, and we are starting to learn a bit more about it. We had few publications in the last 5 years about male BMI. We published our own study. We presented some really interesting data, and we published a systematic review. And I think it's important to remember that male BMI is also important, and there is a move, although it has not been brought into force yet. There's a move to again restrict funding based on male BMI. I'm not sure how easy to achieve that, but it's something that's really important, and we advise our male patients to also try and lose weight before starting treatment. The science before that is extensive, and it talks about oxidative stress on the sperm. It talks about sperm parameters, talks about sperm DNA. There's a lot of evidence around that, but it hasn't been brought into clinical practice as much as we would like as yet. Now, I also want to talk a little bit about our fertility preservation service, which we have recently expanded to include ovarian tissue cryopreservation. And the NICE guidelines have discussed fertility preservation because it's an important aspect of what we offer. We have an oncology fertility preservation service, which you can refer to, have a dedicated clinics for that, because we need to consider the impact of cancer and its treatment on patients' future fertility, overall prognosis, expected outcome of fertility preservation, and expected outcome when we thaw the cryopreserved material. These are all factors that we discuss with patients who unfortunately have been affected with certain types of cancer, and they are being referred by either the oncologist or the GP for fertility preservation. There's also currently some discussions about fertility preservations prior to benign treatment, like extensive endometriosis treatment. And I think this is an area where our primary care colleagues need to also be aware of, because it could come up in the discussion with patients. We would consider fertility preservation if patient is well enough to undergo ovarian stimulation or oocyte retrieval. The treatment will not worsen her condition or delay the starting of her oncology treatment significantly, and there is enough time for treatment before starting cancer treatment. And as I mentioned, we've now extended our fertility preservation scope to include ovarian tissue cryopreservation, which could apply also to prepubertal females affected with certain types of cancer. The NICE guidelines recommended that we use vitrification for oocyte and embryo freezing, which is what we currently do. We'll use liquid nitrogen sperm freezing, which we also currently do. And it's important that we don't apply conventional IVF eligibility criteria at the time of fertility preservation. Those criteria can be applied at the time of using the stored material, but at the time of fertility preservation, patient is under pressure. She is likely to start a cancer treatment soon, and therefore we should not apply the IVF eligibility criteria. They're not having IVF treatment as yet, they're just preserving their fertility. Long-term outcome after IVF treatment and ovulation induction treatment. There's been a lot of research done starting from the 90s until now, trying to see if there is any detrimental effect. And up till now, thankfully, there is no direct link with invasive cancer. There may be a small increased risk on borderline ovarian tumor, but we cannot exclude that risk. But this is a really marginal increase, and it's only borderline tumors. There is no association with any adverse outcome in the children, but we're still doing further research to try and elucidate on this area a bit more. And I think in the next 5-10 years, we will have hopefully more reassuring evidence. Again, they suggested from the NICE guidelines that we do more research on unexplained infertility, the role of adjuvant therapies in IVF, and we have done that, and we're still looking into the role of adjuvant therapies and adjuvant tests in IVF, and how we can best select the highest implantation potential embryo for single embryo transfer, and as I mentioned earlier, the long-term safety of fertility treatment. Now, how did these guidelines affect our practice? I'm very pleased to tell you that all the recommendations that we have discussed are now standard practice in ACU, and we are using those guidelines as an opportunity to promote more NHS funding, particularly in the face of the recent reduction in availability of funding for our patients. What are the factors that affect IVF success rate? And I think we have touched on that over the last 25-30 minutes. Age, how long they've been trying for, have they achieved a previous pregnancy or not? Of course, the outcome of ovarian reserve test is extremely important in determining patients' success rate from IVF treatment, how the ovaries respond to stimulation, which is again related to ovarian reserve test results. And that's why it's really important that we work with our primary care colleagues to ensure that there is a discussion from the earlier stage about the impact of ovarian reserve as well as age on the overall fertility potential. Of course, the number of embryos available and the quality of those embryos will determine the success rate. We talked about how important BMI in determining the likelihood of pregnancy and the risk of miscarriage. And of course, if there's any gynecological pathology, endometriosis, fibroids, hydrosalpinges, adenomyosis, again, these would be indications for early referral because they can reduce the overall outcome of the treatment. But if you ask me, if I want to summarize this slide in one word, I would say age, age, age. That's 3 words, not one, but it's the same one. Now, finally, I just want to talk to you very briefly about our counseling service that we offer in ACU, which we're really proud of. Now, the emotional journey couples go through during IVF treatment and during conception delay in general is really quite significant. It's a constant sense of loss. It's constant sense of losing power. And it's constant sense of uncertainty and unknown and vulnerability and loss of confidence because they don't know how they can help themselves to become more fertile. It poses challenges to the relationship. It poses challenges not just within the couple's relationship, but with the wider acquaintances, friends, and family. Because if they don't have children, they might be reluctant to visit family or friends who have children. And these are stories we hear from our patients, and it really means a lot to us. We try and do everything we can to help them beat their childlessness. Now, the HFEA picked on that recently, and they said that every clinic will have to develop their own patient emotional support policy. It's part of the HFE Act that we are responsible for making sure that patients are looked after, offered counseling, offered support during their fertility treatment journey. And the key issues that we have all been trained into, and we've trained all our staff from reception to admin to appointments to phone calls and call center, to nurses and doctors and embryologists, everybody, we need to be prepared to support our patients. Be empathetic, be clear and calm in the advice we give to patients. Make sure they understand what we've said. Make sure that if they didn't, that we use various techniques to make sure that they are aware. Repeat the message, make sure it is clear, make sure it's understood. But equally importantly, listen to what they want to say. Try and understand their emotional status. Respond compassionately and organize follow-ups. Make sure that they understand what is happening next, because they're always looking for the next step and the next step so they can reach their goal. Now, I think we've done well with time. We've got a little bit of time for Q&A, but before I end the talk, I just want to thank you for your time and thank you for listening. And I'm really happy to take any questions you might have. Thank you very much.
Thank you very much, Tarek. It was a very informative presentation. We do have quite a few questions, so let's try to address most of them, or if not all of them.
Yes.
I'm going to start with the first question, which is, how easy is it to get eggs for women? Is there a waiting list for patients?
Okay, I think this is a really important question, and more recently, probably in the last maybe 1 or 2 years, we have seen an influx of patients wanting to freeze their eggs. Unfortunately, this is not funded by the NHS, unless if it was for fertility preservation for a medical oncological reason. But in answer to your question, it is fairly straightforward. We don't have a waiting list, but most of those cycles will be self-funded by the patient.
Okay, thank you very much. And we have a question from Sarah Huxwell. Should we check for rubella, IgG, BBV, FBC, hemoglobinopathy, screening, etc. prior to referral?
Very, very important, and I want to really thank you for that question. Rubella is absolutely necessary, and that can sometimes be because of delay, because if the rubella is negative, and we do see patients with negative rubella status, it's important that it's tested at the earliest opportunity in primary care, and if the patient is negative, she is offered the chance to have an MMR vaccine 2 doses. Now, with regard to hemoglobinopathy screening, for certain ethnic groups, the answer is yes. If they are from either Afro-Caribbean, Middle Eastern, South European or Mediterranean, Asian background, then we would recommend that they are tested for hemoglobinopathy, which is sickle cell or thalassemia traits.
Okay, thank you very much. As a question, is letrozole actually licensed for ovarian stimulation, as I wouldn't prescribe as the GP if not?
Is it licensed? At the moment, it is not licensed for ovarian ovulation induction, but there are Cochrane reviews and there are guidelines suggesting that it can be used and it is actually safer than Clomid. I think if there is any concern about prescribing letrozole, refer the patient to our ovulation induction service and we can prescribe letrozole, but it's a lot safer and it's more effective and it has less side effects compared to Clomid. And currently we are about to start a randomized trial to look at this particular issue, and hopefully when it is completed and published, then the license will follow.
Okay, thank you, Tarek. I think Nikki Harrison has a similar question, a related question to this. I wouldn't initiate Clomid in primary care, and I am an experienced obstetrician and gynae. Is this just me?
Hi, Nikki. Thank you for that question. I think if you don't have access to follicle tracking, then refer patients for ovulation induction. We have an ovulation induction service, both NHS and privately funded, and you can refer patients to our service. That's fine.
Okay, thank you. And Sarah Huxwell has another question. Do we have access to AMH in primary care, Lewisham?
I would love to say if you don't have access, please do get access. I don't know the answer to that question. but it would be really helpful if instead even of doing FSH, LH, and estradiol, you can just use AMH as your marker of egg reserve testing. I don't know why this is not available to all general practitioners. Is it cost related? We can find, the cost can be found by not doing the sort of the old school tests, FSH, LH, and estradiol. Just do an AMH test, and this will be a more informative test. And it's not related to the cycle date as well, so it can be done in any stage of the menstrual cycle. So it's easier logistically, and it's really an important marker of egg reserve. And again, it could be a criterion that you can use at the general practitioner for early referral when you see that the AMH is on the low side.
Thank you, Tarek. And a question from Dominic. It's an interesting question. We might not know the answer, but I'm sure it's a really good question to ask. There are a few CCGs that apply IVF eligibility criteria for fertility preservation. Will there be possible actions to get these CCGs to change their policy?
I would hope so. Thank you, Dominic, for the question. I think the NICE guidelines are really clear. Eligibility criteria will only apply when the patient returns to use her cryopreserved material, not at the time of freezing. For example, let's just be clear about this. Patient, for example, she's got a child. She's not eligible for IVF treatment on the NHS, but she developed breast cancer, or she developed hematological cancer, or any type of cancer. She can have fertility preservation on the NHS, but when she recovers, hopefully very soon after treatment, and she wants to resume trying for a baby and use her cryopreserved material, at that stage, the eligibility criteria will apply.
Okay, thank you very much, Tarek. Nikki just reflecting on the topic of AMH, and he says, Nikki says it's not funded on primary care, and or other attendee commenting that yes, it's not funded on primary care and telling them to go private.
Yes, and I know, I don't know how we can change this. Nikki, I completely agree with you that it's a cost issue. And I know the cost pressures currently, particularly with the pandemic. I don't know how we can change this, but maybe, with discussions with our general practitioner colleagues and discussions with CCG, then maybe we can utilize the funds available for other tests to actually use those funds to do AMH.
Thank you. And last but not least, one of our anonymous attendee, availability of semen analysis focuses usually on female, but what is available for men?
I agree. I completely agree. I think this is a very important point. I mentioned it during the seminar. It's important that we pay similar amount of attention to the male partner. They sometimes even feel excluded from that process, which is the last thing we want to do, really. And I think semen abnormalities can be present in up to 35–40% of male partners, and it's absolutely crucial that part of the initial assessment, particularly in primary care, is a semen analysis, and patients will be given full result, and it will be included in the referral for secondary or tertiary care. And when that happens, really, we are saving our patients a lot of time. We are saving them a lot of toing and froing, and we are giving them a really good care from the outset. So I think that's a very important question, and I would add my voice to yours, saying that's really important test that needs to be done at the initial assessment.
Correct. On this topic, I remember you mentioned it on your slides that usually when we receive referrals from GPs, we got the referral for the female part, but not for the male. Would you say that we would encourage our GPs to actually refer the male and the female for these assessments?
Absolutely. Sometimes it's a bit difficult because the male partner could be registered in a different practice. But I think it still be useful to include the male in the referral, or even in the letter, if you know, just to say her partner's name is so and so, his date of birth is so and so. I understand he had semen analysis with his doctor, and he will bring the result, and the result was normal, or the result showed oligospermia or showed azoospermia. I think that would be really good, because it would mean that the referral is complete. Patients don't have to wait. There is a reduction in the time to treatment from referral, and that will always help patients' well-being during the treatment and improve her success rate.
Okay, thank you very much, Tarek. I think we, oh, sorry, I think I have one more question in the chat. Let me just quickly look at this. When semen has shown an issue, I'm never sure if should refer to infertility clinic for both parties or purely to andrology. What if both partners may have issues affecting fertility?
Yeah, I think this is a really, really important question, and I thank you for asking that question. I think it depends on the severity. I think it would be reasonable to refer the couple to the fertility clinic. We have access to our andrology colleagues. We have what we call combined andrology clinic, where we sit down with our andrology colleagues and look at patients where there may be an abnormality in semen analysis, or maybe there is combined issues with the female and the male together. And that would be present in about 10-15% of couples, that there's an issue with the sperm, but there's still an issue with the female partner. So if the semen analysis is not severe, i.e. the patient is not azoospermic, then it would be reasonable to refer to fertility clinic, and then we can do a referral to combined andrology. If there is a severe abnormality, particularly if there is an associated symptoms on the male partner, then it would be reasonable to refer to andrology services. So say the male partner has an issue and is symptomatic, you know, recurrent UTIs, prosthetic issues, history of surgery, then it would be reasonable. History of testicular tumors, history of testicular surgery, history of testicular torsion. I think these are all a reasonable indication for andrology referrals.
Thank you, Tarek. Rafiq, the same person who asked this question, asking, can you discuss antibodies to sperm in women? Is this common? Do you check for this routinely?
So this has now been dropped from the semen analysis, that we don't test for antisperm antibodies anymore, because the value of this part of the semen analysis test has never been confirmed really substantially. And therefore, we do not really, in our standard semen analysis, we don't test for antibodies. And if you actually look at the WHO criteria, they don't include antibodies, and the BFS, the British Fertility Society, have dropped the need for antisperm antibody testing. So again, that's something that we would reassure our patients about, but particularly the female partner, because she might be worried about the presence of antisperm antibodies. If the motility is normal, and if the count is normal, and there is no influence of the antibodies on sperm motility, then it becomes less significant.
Okay, thank you very much, Tarek. I think we managed to address all the questions, and thank you all of you for the questions. It was very engaging. And I'm going to hand it over to Monique to quickly finish off the webinar with some information that can be useful for all of you. So please just stick around for a couple of more minutes. Thank you so much, Tarek.
Absolute pleasure. Thank you.
Thank you so much, Tarek and Eniko. Those are some fantastic questions, and it was a really, really informative webinar. So thank you so much. Just a quick finishing off notes there. So in regards to the certificates, you will all receive a certificate within a week of the webinar, and a recording will also be included in the email that follows up as well. In terms of referrals, if you would like to refer to Tarek or to any other of our team members, All patient referrals, you can contact our private patient inquiries team. All of these details will be sent to you across in the follow-up emails as well. Alternatively, you can get the information from our website direct or across our socials, so that's our Twitter and our LinkedIn account. Please do, we invite you all to join us to our upcoming webinars as well. Staying on theme to our women's health series, we have Mr. Con Kelleher, who will be doing a talk in September, and we have Shri Sankaran as well. She'll be doing a talk around pregnancy and COVID, and then we also have Mrs. Jan Grace in November, who will be doing a talk on fertility assessment and referrals. So yeah, please do sign up. All of the links to those are on our website, and we will also be posting on our socials as well. So if you've all signed up to our mailing list, you will also all receive email in the next couple of weeks for those as well. Any questions, please don't hesitate to contact us, and thank you so much for attending. That was fantastic.